disease? Any suggestions? Yeah?
When food stays longer in the GI tract, it's slowed down.
So it slows food digestion,
Yeah.
and that's a good thing
But
to prevent.
it's a bad thing to have that. It's good for fiber and have it faster time.
Slower transit time because of fiber, and that helps prevent
Oh yeah, sorry.
which
the other way
disease?
around.
Oh, the other way around. Okay.
Oh yeah, because this is not the same for passion.
I just show some examples because we have no time to go deep into that, but just for you to get a feeling what kind of questions you may have during the exam. If you have saturated fat, I would love to see some explanation on how that impacts your cholesterol, which type of cholesterol. I realize that I don't go deeper into all these different types of cholesterol like LDL, HDL and so on, because I think it's already assumed knowledge. To some extent, you had a lot of biology classes and other type of lectures, so I don't want to repeat too much. But if you feel you lack this knowledge, then take some time to catch up. Yeah, and also later on during the course, there will be a lecture also on lipids, and you will see these cholesterol fractions again. But of course, this is a major pathway, saturated fat leading to coronary heart disease. There's a high salt intake that could be a pathway to high blood pressure and then to chronic kidney disease or stroke or any other outcome. And here you can have low fiber intake, may contribute to obesity because of less satiety, or could maybe generate in the gut microbiome the short chain fatty acids that could also impact some disease risk. So there are all kind of pathways, and this is just bullet wise, but in the exam I would like you to elaborate a little bit on that and to describe in a bit more detail these different steps. Okay, so let's go to the second part of the lecture, and that's about prevention. I told you already that genetics alone do not explain most of the cardiovascular disease, and you can also see that happening, like now in China, India, these countries. There's enormous epidemic of cardiometabolic diseases in 10 years' time. So, and that cannot be due to a change in their genetic factors. And so every population that moves from a healthy society to a more unhealthy living environment will develop cardiometabolic diseases within one generation. And that cannot be due to genetics. That must be environmental. Of course, people with certain genes are more susceptible to developing disease, but these genetics alone explain only a small percentage of the disease. And that is also an important notion when you look at the risk factors for cardiovascular disease. Many people differ in the reasons why they get, for example, a heart attack. And I have two virtual people presented here. Mrs. A, she has obesity. This guy smokes a lot, and this one doesn't eat fruit and vegetables. And they all have different, what we call component causes. Maybe this woman does not smoke and eat much more vegetables, and maybe he eats a lot of vegetables while he smokes a lot also. So there's different sets of risk factors people have, and we call these individual components, we call them component causes. Only when they have a complete set of component causes, then they develop the disease. So that's why your grandfather who ate a lot of bacon didn't get a heart attack. No, because his pie was not complete yet. And he was adding risk to getting the disease, but still he might have been protected by some other factors. Maybe he did a lot of exercise, or he lived in an environment with little air pollution, and so it's always a set of component causes that make it into what we call a sufficient cause leading to the disease. And so, but there might be some causes, some component causes that are necessary for developing the disease. Like for getting breast cancer, you do need breast tissue, for example. That's a necessary cause. But mostly it's the set of component causes. And sometimes there is a necessary cause that's present in every person who develops the disease. And that it's quite interesting. That's why the dietary guidelines sometimes don't work for all people in society, or why some therapy doesn't work for all people. And they have different sets of component causes. Well, here we have some grandma. She smokes and has a birthday cake, and she lived really long. She was over the age of 100 when she died. What we actually say in epidemiology is that when you have a healthy lifestyle, you live longer on average. It doesn't apply to every individual in that population. It's the average individual in a population. And so you can consider the population in fact as one big average individual. And for health policy, you direct your guidance towards that one average person, which in fact does not represent every individual, but only the average of a population. This is quite important for public health strategies. And then I come to the prevention paradox. And this is, for example, the distribution of blood pressure in a society. And what you do with dietary guidelines or with other measures, you try to shift that distribution to the left, that on average people have a lower blood pressure. And it's important to realize that most cases of cardiovascular disease occur in the people with mildly elevated risk, not in the ones who have a highly elevated risk. Of course, these people individually have a high risk of getting cardiovascular disease, but it's only a small segment of the population. So in public health, you want to shift the distribution toward a lower level for blood pressure, for body weight, for cholesterol, for exercise a little bit more. And it doesn't, for an individual, it doesn't make a difference whether the blood pressure systolic goes down by 2 or 3 millimeters of mercury. That's nothing. It's even in the measurement error of the doctor's device. But if you achieve that 2-3 millimeter lower blood pressure on a population level, you may prevent 10% of heart attacks. And so that's what we call the prevention paradox. We treat populations that have only a mildly elevated risk that don't come even to the attention of the medical doctor. And therefore epidemiology and public health policy is so important. This is a concept to think about that you had also in your course on epidemiology and public health, and it's very important for all kind of prevention programs, and why diet is still important even if it has only a small impact on the individual level. So I have explained it here also a little bit further. So this is why we have these mass campaigns, food reformulation strategies, infrastructure for cycling, and so on. That's all important for the prevention of cardiometabolic outcomes. I also want to tell a little bit about the risk markers and risk predictors. So if you want to do prevention in society or even in an individual, you can only have an effective outcome if you treat a causal risk factor. If a risk factor is somehow connected to the exposure in the outcome but not really acting in the body, then it's useless. So therefore it's important to think about causality. So we have a couple of causal risk factors. We know blood pressure is a causal factor, LDL cholesterol. Why do we know that? We know that from all kinds of drug intervention studies. When you lower the factor, you get less events of the disease. So when you intervene on that, you get less heart attacks and less strokes, for example. But there are also factors that are associated with the disease, but there can be a consequence of the disease, for example. So you measure it in the body, like CRP in the blood can be a consequence of the infection or the atherosclerosis that's already taking place, and a marker of the disease, rather than causing the disease. When there's some classical example that people who smoke a lot have yellow fingers predict these people's risk of lung cancer, but treating the yellow fingers doesn't do anything to the lung cancer risk. So it's a consequence of the exposure, but not causally related to the outcome. So there can be innocent bystanders, like the microbiome will change after you eat different types of food. Is then the microbiome a causal factor, or is it just reflecting the different food intake? It's not always clear whether these intermediate factors are causal in the pathway. It can just be a consequence of the disease. Although they may not be causal, they are extremely important for the prediction of disease. Sometimes it doesn't matter whether you know whether people smokes or whether he or she has yellow fingers. In the prediction model, they can be of value, of equal value. Do you get that? So medical doctors, when they predict the risk of future cardiovascular disease, when they have a factor that's closely related to the actual exposure, but not causal, it's still very important for risk prediction. So there's some debate for the HDL cholesterol, which I think is not causal, but still very important for the prediction of disease. C-reactive protein in the blood is an inflammatory marker. That's also debated, whether that's causal or just a consequence of atherosclerosis or other infections going on. Okay, well, I already mentioned a couple of times the epidemiological cohort studies, and they are really important for understanding the risk factors of cardiovascular disease. Cohort study, you start with like a cohort like you. Some of you may be eating French fries on a regular basis. Others never eat French fries, so I could make two groups out of you. And then I follow you throughout the course. And then I take your blood pressure at the beginning of the course and at the end of the course. And then I can check, do people who eat a lot of French fries, do they have higher blood pressure than the ones who did not eat French fries? That's a simple cohort study. So cohort study is just people have the habitual diet, habitual lifestyle, and you measure that and you link that to future disease occurrences or mental well-being or your blood pressure or the risk of getting diabetes. That's a very common study design that is the basis for a lot of risk factors that we know now. And I will mention a couple of studies that are hallmark studies in epidemiology that you just should have heard about that. And one of them is the 7-country study that was initiated in the 1950s, where they compared different countries. You can see here the different countries and the saturated fat on a country level, the cholesterol in these populations. And Ansel Keys was the founder of this study, and he found that there is some association between the saturated fat and the cholesterol level in these countries. Netherlands is also part of the 7-country study. I think the picture is not correct because Netherlands is even bigger almost as USA, but never mind. But these are 7 countries where they learned a lot about the classical risk factors for cardiovascular disease, mainly coronary heart disease. So you should have heard once in your life, and that's now, about the 7-country study. Okay. Another important study is the Nurses' Health Study and the Health Professional Follow-up Study, the Physicians' Health Study. There are many of these big American cohorts that were also initiated in the 1970s, 1980s, they are still followed. These cohorts are still followed, and even their offspring is followed, or people are added to the cohort, newly added to the cohorts. We learn so much about diet disease associations from these very long-lasting, quite big cohort studies in the USA. Walter Willett is a founding father of many of these kind of studies. I think you know him personally, Neha? Yes, you worked even with him, I guess.
He was my advisor on my PhD.
He was your advisor during your
On my
PhD.
advisory board, whatever, you know.
Yeah, okay. He's a nice guy. I think he's vegetarian or vegan even.
I don't know about that actually. Maybe
Well,
now
I
he is.
had quite debates with him about dairy foods. He thinks dairy should not be consumed by humans, it's for the cow and not for... So that's quite interesting. Anyway, nice guy, he does a lot of important work, and that group at Harvard Medical School has produced a lot of scientific papers that you will also study during this course. Then we have the Framingham Heart Study. That was really, I think, the first study that found out the term risk factor for cardiovascular disease. It's a small town, I think close to Boston in the USA. They set up a study, a cohort study in 1948, just to find out why do people get CVD. At that time they knew nothing. We know a lot now, that's because of them, but that time they didn't know why people died from their heart failure or these kind of diseases. And they studied all these kind of factors, and they found out that high blood pressure, high cholesterol, I think also diabetes, that these were major risk factors for cardiovascular disease. At that time, obesity was not that prevalent, so it was mainly focused on the vascular part, blood pressure and the cholesterol. Okay, and from there they developed the Framingham risk score. That's a kind of algorithm to predict somebody's 10-year risk of getting a CHD. And the first formula was published in 1998, and it's still updated. So that's a prediction model that clinicians use and also policymakers may use for future burden of cardiovascular disease. In the USA, they now have this wheel of 8, so the life's essential 8. I used to have 7, but I found out that they have added the healthy sleep now as a major lifestyle factor for the prevention of cardiovascular diseases. So these are the most important targets for public health policy and also for treatment to improve on these 8 lifestyle factors. This is for the USA, but it's also similar, I think, when you read the paper from the European Society of Cardiology, you will also find all these building blocks, so to say, for CVD prevention. So now I come to the European guidelines, and that's also based on the same risk factors as we discussed for the Framingham study and for the USA algorithm. It's always age, sex, LDL cholesterol, blood pressure is in there, smoking is always in there. And in Europe we use what we call score charts. So these are just kind of matrix. It's a matrix where you can find a combination of all sets of risk factors and the 10-year risk that belongs to that specific set of risk factors. And it's quite complicated when you look at it, but it's quite easy to use. So what they do, they have separate score charts here, for example, for older people in different geographical regions. So there are high-risk regions in Europe, low-risk regions. This is, they derive these models through cohort studies and other type of evidence, and then they classify people, and they just measure in these cohort studies who gets the disease and who does not get the disease, and they validate that again in other cohorts, whether it's really a good prediction model. So here you can see one of these score charts. This is for a low-risk country, that's the Netherlands, for example. On average, our risk of CVD is lower than in Bulgaria, for example. And so you can see here, I think I put myself here, yes. I have a 3-year risk of developing cardiovascular disease in the next 10 years. So you can see me here. This is I'm non-smoking, my cholesterol is 5 to 5.9. It's a little bit elevated. It would be better if it is under 5, but I have a slightly elevated LDL cholesterol also. My blood pressure is around 115. My blood pressure is not very high and I'm age 58. So I end up here as a woman. And you can also, you are still young, much younger than I am, so you are not yet in this chart, but as soon as you are 40 plus, you will be able to see your 10-year risk of getting CVD. And it's quite accurate. It's based on a lot of data. So I am still in the green area, so I don't have to worry. But I think that overweight, obesity should also be in there, and then I have to worry a little bit. So I think it's still not fully capturing all of the risk factors. They have this kind of flow diagrams for people who don't have CVD yet, so for the general population, but they also have treatment targets in that cardiovascular risk management strategy. That's how it's called, CVRM. They also have that for people with CVD. This is for people without CVD, so you can go through the chart and see what should be done when somebody's under age 50, have that certain risk that I have, like 3%, consider risk modifiers and so on. No additional prevention, others will need some treatment, and you will end up somewhere here for specific types of treatment. This is for people with CVD, so there they have also all kind of charts, and you will learn about that in the clinical week, but you can see that there's a different strategy for people who already have developed CVD. And for people with diabetes, for example, the blood pressure is more important, so they treat blood pressure more seriously than for people without diabetes. So this very fine-tuned to groups of individuals. And you don't have to learn this all by heart. Only maybe some targets like blood pressure 140, 130 is important. Main targets for cholesterol is important, but it's just for you to know that this exists. And what you can see also here is GLP-1 receptor agonist, where you are going to work on in the group work, because that's a novel treatment, the Ozempic. It's really effective in lowering blood glucose and body weight, and it will change the whole era that we are facing. I think this will be a major game changer, these type of treatments, and that's why we also dedicated the group work to that you are front runners after this course, you know all about it then, because it's really having a lot of impact also on our research. Oh, there's Kim Kardashian, who used it. I think she was more beautiful before actually, but well, that's my opinion. There will be also some lectures on the bariatric surgery and alternative treatment for weight loss by a bariatric surgeon who does these treatments. So I think it's quite interesting to learn from him. Okay, so tomorrow we are going to talk about dietary patterns, types of which diets, which foods. This is a kind of teaser. This is the current dietary advice for the Netherlands by the Dutch Health Council. Shift toward a more plant-based diet. I learned from Nea you could also call that a plant-forward diet. That's a new term that I learned. And these are the guidelines for the Netherlands at this moment. You probably may know that. And there's no need for dietary supplements unless recommended for specific target groups. This should fulfill all your nutrient requirements. The guidelines for cardiovascular patients and diabetic patients do not differ much from those of the general populations. The Health Council advises a bit more fish for people with cardiovascular disease, and they give more focus to weight loss for type 2 diabetes, but no need for low carb diets, and I will come back to that tomorrow. This will also be part of tomorrow's lecture, so I will skip that in this one as well. I had too many slides here, so this was it for today. Tomorrow we discuss the dietary patterns, Mediterranean diets, the omega-3 fatty acids, the healthy plant-based diet from the Eat Lancet Commission, planetary health diet it's called, by the way. But for now, do you have any questions for this lecture on risk factors and how to determine risk of disease? Was it clear? Am I going too fast? Is it too complicated? You are a diverse group of students, so I don't know about all of your background. Some will have knowledge of epidemiology and think, oh, that's boring, don't talk again about cohort studies, I've learned that. Others will know a lot about molecular nutrition, they are not interested maybe in these parts, but if you feel that it's not connecting to your background knowledge, please just let us know. Maybe we can give you some extra materials. Or... Okay?
I have one question about this slide. I don't know.
Yes, I can go back. This one.
Yeah. So it compares the different regions.
Yes.
Are they taking an age range or one age?
No, they do the same age categories within every region. So it's really fine-tuned. So for every region, like Netherlands is green and the Mediterranean countries as well. Well, Finland is moderate risk and Russia is very high risk. And so for every region, they have stratified their analysis in age classes. So it's a lot of work. There's very much data goes into this. Yeah, I don't say that all regions are as accurate. Some regions have better data than others. So I'm not sure about some countries whether they have good cohort studies to base this analysis on.
So then they don't necessarily only compare age 70 to 80, not different regions, but also 60 to 70.
Yes. Okay, that was it for today. Any more announcements from your side, Nea?
Yeah, because we still have a couple of minutes more to the end of this class. If you have no questions for Mariana, and if Mariana, you're okay, may I just take a couple of minutes to make some announcements?
Yes,
Yeah?
please use the microphone.
Okay. All right, everybody. So, the first question is about presentation of our group work. If you've had a chance to look at the schedule, this is slotted for the 5th of December, which also happens to be Sitter class. And as it turns out, I'm not sure if you are going to be participating, but Impulse and a lot of the administrative staff are. So the building will shut at 4 o'clock. So I have a request to make. We normally schedule our afternoon sessions between 2 and 4. If the building itself is planning to shut at 4 and it's a Friday, I wonder if it would be at all possible to move it by at least a half hour or maybe even 1 hour. So what I'm asking is it possible for us on Friday the 5th to have our group presentations between 1 and 3 instead of 2 and 4? Does that conflict with any of your other engagements? I don't need an answer from you just yet. I want you to think about it. I will send all of this information in email, but because it's so, I wanted to give you some background so you'd know why I'm asking. It's because our administrative staff and our impulse building staff are gonna celebrate Sinterklaas. So that was one element to run by you. The other was just to remind you again that, you know, some of you will ask me this about the use of slides for exams and how much content that should cover and how to balance out readings, etc. While Mariana is here, I think it will be good for us to get a sense of that as well. My reading is that content from this year is very important. Please look at your slides. Please go through the readings. Your exam questions will be based on all of them. For those of us who are taking this class again, please make sure that you're following these slides and not slides from last year, because again, your exam questions are going to reflect this new current content. Is that correct, Mariana? Yeah? I think that was pretty much it. As always, I would encourage you to please be present in class. There is going to be quite likely a video recording that will be uploaded as soon as I get it, but you know, there are always technological glitches. Please don't rely on those recordings unless you need to in extraneous circumstances. Yeah?
I have one more remark,
Yes,
because I put a couple of slides here to prepare for you for tomorrow. If you have no epidemiology classes, please go through these different setups of a cohort study and a randomized controlled trial. And there's also an example of how to calculate a relative risk. So practice with that you know how to calculate a relative risk, because you will also need that during the group work, understanding of the literature, and that you understand the difference between a randomized controlled trial and a prospective cohort study. It's quite important for the remainder of this course as well. Okay, well, thanks a lot. So